So the first thing I'm going to do is I'm going to see if I can share this without having a challenge here. Can you all see my slides?
Yes, yeah, I see them.
Yes, we can.
Perfect. Let me just, it's just adjusting to the change in the format. All right. Again, can you see me well? Can you hear me well?
Yes, we can.
Great. Thanks, Eva. Good afternoon, everybody. Thank you for inviting me. It's a pleasure to be here. It always feels strange to do these things via remotely. I used to really look forward to getting invited to visiting, and I really thank Dr. Spector, Michael, and Kinchik to invite me. Somehow the technology and the distance has taken out some of the joy, and so Michael, you still owe me a big bottle of wine properly, and just because I can't be there now doesn't mean you don't owe me that. So let's think about that. But the real larger issue, which I'm fascinated about, is how COVID is changing things. And so this is an interesting overview of my thoughts on why bioinformatics is so critical now, but also some of the lessons that we've learned that might be relevant to this conversation. But I'm going to start with something which I don't think enough bioinformatics programs do, is that it is not about the information. It is all about the system. And now the question is, how can informatics teachers, faculty, staff, researchers help the system become a more effective system, a more well-aligned system, a system that's just, socially, morally, ethically, as well as financially value-driven, that is always about the patient at the center of this equation of population health, the quality of the system, and of course, the joy of the providers. So as we think about what systems mean to different people, let's look back at what the data shows. So this is a brief snapshot over the last 10 years. This is what the data shows around the world, that about 1 in 10 patients are harmed in hospitals and clinics. In low and middle income countries, it's probably about 1.5-fold that. A lot of people, both medical and surgical, are being harmed, and a huge amount of waste. And you can see this data from the National Academy of Medicine, from the Lancet, from OECD. Around the world, this problem is that healthcare doesn't deliver on the value that it should. Here's an example in where physicians, despite having very clear guidelines, don't follow on the guidelines. So even though when we have evidence-based, we stay stuck on these evidence. So patients then get highly variable care, and that highly variable care leads to waste, leads to harm, leads to failure in services, and ultimately undermines the engagement and loyalty of providers. So since I've moved the screen, Michael, to this one, I can't see the chat. So if there are chats, just call me out and I'll be able to see them. So here's an example of a fascinating thing. And usually in a class, I would ask by show of hands, but I can't do that right here. How many of you think that checklists are an important solution for reducing surgical morbidity and mortality? And I'm sure you've all read about this many years ago. This was highlighted, and checklists certainly have a place. However, what emerged very clearly is that while the checklist, if used well, could drop the mortality and wrong-sided surgery, in fact, in Canada, 2 years after this major publication that came out by the WHO and Atul Gawande, what they showed in Canada is that 2 years in, the same checklist that they talked about had zero impact. And the real question was, how could it be that a checklist that seems to work in an experimental model does not work in the real world settings? Is it a problem of implementation? Is it a problem of translation? Is it a problem of simply the experimental model cannot be replicated? These are really important questions for informatics and systems learners to understand. Why is it that despite the evidence that we have in the laboratory or in a pilot project, why is it so difficult to carry this through? And what are the elements of learning sciences and information sciences that are relevant? Another project that Peter Provost did, looking at central line bundles, and what became very clear is that the same model that was applied 40% in the infections caused by central lines, when that same model was replicated in London, there was almost no benefit. And what it became very clear was that while the checklist was a technical solution, it could not work without an adaptive social cultural framework. And that's really the connection to informatics. What is the framework upon which technical solutions, in this case checklists or other types of interventions, can work, and what is the role of informatics to help drive that relationship? Here's some more data. This is from the advisory board, very interesting data from around the world. And you can see here that if physicians are engaged, patients are happier. If physicians are engaged, medical errors go down. If physicians are engaged, the hospital makes more money. And ultimately, the overall mortality is directly related to the engagement, not the knowledge, not the evidence, the engagement. So how do we use information systems to better engage nurses, physicians, and other clinical people? And what is the language, the linguistics, the mental models that we have to think differently if you're going to be able to engage providers differently? Parenthetically, I imagine you've read about the fact that close to 50% of physicians in multiple studies have signs or express signs of depression, burnout. With nurses, about a third of the nurses on average either change jobs, resign, or become traveling nurses. This has gotten even worse during COVID. A lot of these epiphenomena suggest that while we're driving more technology and more engagement, we're struggling with the inability to engage our clinicians. Michael, I think you've raised a hand, so please.
Yeah, I did. I raised my hand because it occurred to me, I was trying to figure out how to do this. But yes. I had a question back when you said that the experimental study showed an impact of a checklist, but then in practice, no impact. And I was wondering, some research I did showed that when people are in training, they tend to follow the training guidance, but when they get into practice, they start taking shortcuts. And I was wondering if that might be one possible explanation for the difference.
It could be. I mean, you raise an important phenomena. In this study, this was people who were, it was a training facility where they did this study. And so there was a lot of eyeballs on the process. So it'd be difficult to suggest that this process was different than what they did every day, although there could be variance from training to practice. Another thing I'll talk about later, Michael, is normalized deviance, a phenomenon that Diane Vaughn speaks about. And I'm gonna, since you've asked about it, I'll just highlight it. This is her book. It's an important book about why technology fails. And it's all about where the informaticians are not given the opportunity to tell the truth. And so remind me if I don't come back to that.
Okay, I remember that from, your work in Miami.
Yeah. So going forward now, I went to Wikipedia. I looked for the definition of bioinformatics. This is what they said. I don't know if you guys agree with this. I pulled out the narrative. I just took the graphics. So this is their representation of bioinformatics. Then I went looking at very interesting, this is a workshop that happened in Cold Spring Harbor, and they were talking about what is the future of bioinformatics and some of the solutions. And it was interesting how these different mental models about what should be part and how do we better capture these things in our curricula and our research and our understanding. Here's another model. This is from AHRQ, the Agency for Healthcare Research and Quality. Different ways to think about this topic of medical informatics, and Michael, you've shared with me that the three departments, which I guess are represented in the college as well as on the call: information science, learning technologies, and linguistics. And obviously, there's so much more around this. And so, what an incredible space to be part of, and particularly in these days of COVID, as we'll talk about when I'm going to give you some case studies. So why informatics and why now? I mean, it's clear that we need to make better decisions with information, with processes. It's clear that better information produces better quality, better value, less harm, better service. But it's also clear that information by itself does not do so. In fact, the more money you spend on poorly, clunky designed systems, it turns out that the more problems you have, not better problems. And so it's clear that it's not just about better information, it's about better structures for governance, it's about better intersection understanding of the culture and context. And like a famous Russian cartographer, the map is not the territory. Just because you have an information map or a data map or data dictionary doesn't in any way make or guarantee that you're going to make better decisions, particularly when you don't teach informatics students and faculty the social sciences. and they don't get to learn about evaluation sciences. And most importantly, you don't teach them engineering sciences such as human factors. So I want to make the case, because Michael had asked me for, that the future of informatics must include those sciences, because it's clear that without them, at times, the wisdom of informaticists falls short in actually changing systems because of challenges that come from different spaces that I've alluded to. We know that the principles of better data, better interoperability, better strengthening, enterprise architecture approaches, and collaborative learning. But I want to add Asimov's robot rules, which I'm going to talk to, which is do no harm. So is there a course on ethics in the college, Michael?
Not directly that I know about.
So I would argue that of all the people now who have the largest ethical conundrums right now with COVID, those are people sitting on information. The danger of using data around COVID, as you might have heard, dozens of people who sit on informaticians have been fired in the last year in the US. Most famous was the head of informatics for the state of Florida, who wanted to share the honest information about COVID, but the governor of Florida refused to allow it, so she was fired. The idea of what is the ethical challenges and enabling opportunities for experts in informatics and sitting on data, when should they have an obligatory responsibility to speak to data and bring it forward when the system doesn't allow it? And particularly in times when data is highly compartmentalized or there's a culture of concealment and secrecy. So Peter Senge, one of the forefathers of modern organizational change and linguistics, talks about in his book, The Fifth Discipline, that we don't make decisions necessarily based on data. We make decisions based on our beliefs and mental models, which then use the data to support our assumptions. So the danger, of course, is that we go into a meeting not with an open mind, even though we think we have, but preconceptions, because we know we're going to meet with our dean or our chair or our antagonist, and we're sure, therefore, that the decision-making process will be corrupted. What Senge argues is that the need to be more reflexive about our mental models. So before we go into a key decision-making process around teaching or around patient care, around policy making, we have to make sure that we check what are our assumptions before we get the data. Otherwise, there's a risk of getting locked into flawed mental models or groupthink. I don't have time to go in deeper on that, but there's a huge literature about the dangers of what happens when like-minded people assume data represents either a danger or opposite. And you can imagine how this applies to locking down and not locking down across the US. I was just in South Dakota last week, which has the infamous nature now to be the highest infective rate in the entire US. It's close to 45%. And the leaders in the state of South Dakota believe that there is no need for social distancing or masks, which is extraordinary when you think about the carnage that COVID has caused in the US. So another way to think about, data and knowledge, these are the types of graphics that I'm sure you've seen. They seem very straightforward and simple, but of course, what's missing, the space between the boxes, is what I would argue is almost more important than what's in the boxes. It's not so much if it's HL7 or the data sources are reliable or if it's ICD-10 or not. It's do the leaders around it have the tools and abilities to deal with the understanding of the limitations of the databases, of the assumptions that we make when we align and link databases, and of the dangers of not understanding what that means when we present it to clinicians or otherwise. Lovely graphics about architecture and enterprise, and it all looks very graphically pleasing and looks lovely. But how often does the decision-making about procuring, for example, a large EMR follow this pathway? Parenthetically, I should tell you the number one complaint of healthcare providers in the US is clunky, poorly designed electronic medical records. And so despite being one of the largest financial outlays in the last 10 years, $20 to $25 billion, it remains a bone of contention because clinicians feel that these systems take a huge amount of time, a huge amount of workload, distracts them from being able to talk to patients, and contributes to their overall depression and unwellness. So what was it about the way the systems were designed, if it's Epic or Cerner or others, that instead of actually facilitating the workflow, instead of bringing joy to the nurse, instead of making it easier for the provider to go home at 6 o'clock, as opposed to in the US, on average, physicians take home 2 hours of paperwork, because of the EMR and productivity drivers doesn't allow them to finish the charts. So we can follow forensically and see how many extra hours they're doing at home, unpaid for work, you can argue as well, because of the poorly designed information systems. So what does this all mean for us right now? COVID, of course, has pushed really hard on these issues of self-care and chat boxes and remote patient monitoring. And this is part of the toolkit of all hospitals since COVID. There's been an increase of 5,000, 10,000%, remarkable numbers. But have we actually solved the problems that were related to telehealth and telemedicine prior to COVID? Have we solved them now with COVID? Has this innovation actually led to increased better outcomes? So I would argue that the COVID has been an incredible opportunity to drive telehealth, telemedicine, to hugely increase the demand for thoughtful informaticians, but has it actually improved the outcomes of patients? How much of it was purely commercial and PR? How much of it, the jury is still out? Here's an example of ventilators. You probably remember everybody talked about ventilators being a serious problem. There weren't going to be enough of them because it was happening in Italy. At the end of the day, almost none of these ventilators were used, and most of the ones that were bought were flawed. Look at Jamie Dyson in a moment. We'll come back to Dyson fans in just a moment. Hackathons have been great. Lots of interesting expertise with lots of informaticians participating, frugal innovation using, duct tape and plastic to try to design solutions. At the end of the day, how much of this creative energy actually was implemented to improve the flow of patient care? Here's another example of accelerating diagnostics. So the NIH has spent about $6 billion. Question is now, 8 months later, how much of that has actually improved new technologies or new drugs, despite all that outspend? Here's another example of COVID-19, a huge amount of innovative diagnostics, all supported by powerful informatics, powerful information scientists. How much of this has actually improved the outcomes of patient care? Another example of repurposing drugs. How many new drugs are out there that actually help patient care? At the end of the day, steroids have been shown to have zero benefit beyond the initial foray. Remdesivir, the drug that was haloed, very, very little benefit. It's fair to say that right now, on November 5th, we have no targeted drugs really for COVID. The reason why things are getting better is because we're learning to use old therapies much better. But there have been no large mass scale drugs, despite a huge amount of money, an incredible amount of investment of time and energy. And the question is, did we go about this well? Have we learned from previous pandemics and previous emergencies to use our money more effectively? Here's the use of AI to repurpose drugs, but none of these drugs have actually arrived at the bedside. Now close to, 1.2 billion people infected in the US alone, 8 million people and 240,000 dead, and around the world about 1 million. We can learn a lot from previous pandemics about vaccines. How many of you believe that the vaccine would be ready by yesterday, election day? Of course, it was very, very silly because in 40 years of vaccine development, there's never been a vaccine that has ever been put in place prior to 2 years. So now we're 8 months into it. There's 175 companies that are not sharing data, that are competing with each other. There is no data to suggest that any of these vaccines will be ready before the mid of 2021. And that's okay, because that's what science suggests before we got down this rabbit hole. The problem, of course, is that the false assumptions and the false guidance has led to a lot of loss of further trust, further loss of social trust in government, in NIH and BARDA and CDC and the rest. And that in many ways might actually be one of the worst lasting outcomes of the pandemic in the US, is the loss of trust in our public health institutions. Now shifting a little bit to learning.
Oh, if I can interrupt you briefly, I just had a quick question in regards to what you're saying. Is there a way that we can cut through that type of noise, or is the damage already done?
The damage is irreversible, Eva. What will need to happen now is to start building from scratch. For example, as you know, prior to COVID, about 20% of US citizens were vaccine hesitant, or felt that vaccines would cause harm. Recent surveys have showed, Eva, that in the US, close to 50% of people will refuse to get a COVID vaccine because they don't think it's safe and because they're afraid that the vaccine could cause more harm. which is
Yeah.
really tragic because not only is this feeding into, and you're probably aware in the last several years in the US, particularly in the West Coast, there's been multiple mini epidemics of measles, rubella, mumps, because a very safe vaccine has been targeted by anti-vaxxers. And so the herd immunity, true herd immunity, not the way it's been bandied around in COVID, herd immunity went down beneath 85%, which is more or less the threshold. And so now many more people are at risk of what we might call common infectious viral entities, much more than COVID. And yet the overall willingness to get these vaccines in the entire Western world is now about 78%. It used to be 85, 89. There are countries like France where it's down to 67%. So this is an incredible risk on illnesses that we know are very contagious. So measles, mumps, rubella are multiple times more contagious than COVID, perhaps not as dangerous, but 5 times more contagious. And yet something that works is not going to be endorsed or adopted because of this anti-vaxxer movement. Michael?
Yeah, can I add a little bit to the Ava's question? This is
Please.
Mike. Yeah, it seems like this is actually a double-edged sword because on the one hand, Americans especially expect technology to solve the most complex problems. And then on the other hand, we're losing confidence in the people developing the technology, the drug in this case, to be effective. So
Yes,
we're betting on technology and we're reluctant to use it.
Yeah, that's exactly. And so, this reminds me that if there's not a course in your program, Michael, for change management and how we change organizational cultures, then there should be. So here's another. I'm going to pull out a few books since I would usually bring this to my lecture. So I'm just going to show them here. This is probably the Bible for how to get people to change their behavior. It was written about 30 years ago, Don Schoen from MIT. And what he argued very clearly is that cultures are not just something you measure with a tool. Cultures are how people solve problems together and how they go about managing that. And it's fair to say that we have spectacularly failed to manage COVID in the US. And the damage, the long-lasting damage above and beyond the terrible tragedy to those who have died or the 20% who are likely to have long-lasting neurological injury is the damage to the culture. So moving on to how we learn, I promised you Asimov. So when I grew up, this was my fan. Hopefully many of you remember Asimov. If not, you must read this. The 3 robot rules are essential, I think, for teaching informaticists how to support their leaders, executives, CEOs. And when I think about Asimov and I think about one of the rules for informaticians must be that if you collect data, if it harms people, then you should speak up. Just because you're an informatics person doesn't mean you should do it. And so I'd like to think about the ethics of robots and Asimov and science fiction and how we can bring that into the curriculum at the University of Northern Texas, Michael. So this is what they've promised us. So it used to be old stuff, right? It used to be stethoscopes, which now are more like dating devices in Grey's Anatomy. Then it was medical platforms like wearables and health analytics. And everybody keeps on saying that robotics and AI and augmented reality is going to change everything. And I've been hearing about AI for 20 years. And Stanley Kubrick in 2001 Space Odyssey, 51 years ago, talked about it. And yet 51 years later, there have been some improvements with these tools, but it's a far cry than what was promised. And it's a far cry from the amount of money that society has spent on it. This is not an argument not to invest in the research. It's an argument to be more honest about the limitations of these technologies and big data systems. And I think it's really important because it really goes to this question of learning systems. In addition to the technologies, how much are we invested in the science of learning? For example, this paper in the middle, written by the Lancet 5 years after the major height of the epidemic, argued how much of the first 5 years of decisions, in hindsight, were well decisions. 85% of the decisions made at the macro, meso, and micro level were felt by a group of experts to have failed the mark. How many decisions are we going to look back on in the year 2000 in a year or two and say, this was a complete waste of money? This is a complete waste of resources. We panicked. We didn't use our wisdom from 20 and 30 years ago. We didn't use the wisdom from SARS. We did not use the playbook that the Obama administration kept. It was a 500-page playbook that was completely ignored. How much of the loss of harvesting of learning contributed to the panic, the waste of money, and ultimately the endangering of patients? So this is really a reminder that while COVID has promised to increase creativity, I would argue that from the learning technology perspective, we still have tough challenges to understand the complex ecosystem of hospitals and healthcare systems, the complex regulations that allow innovation, understanding what it means to apply human factors principles, and the siloed professional cultures, which we see are very common in healthcare. Now back to Jamie Dyson, one of my tech heroes. Jamie Dyson wanted to invent a ventilator very quickly, but he was told that he would have to go through 9 months of regulatory approval because he doesn't have all the prerequisites that the other big companies like Siemens and Philips had, and so he decided not to do it. But it was an interesting example of how disruptive innovators tried to, but the regulatory system sort of blocked them. So this is Jamie Dyson's story. So now an example. So I'm a clinician, and as part of that, in addition to my clinical work, I also advise organizations. So I've been advising Jefferson College of Population Health. So I want to tell you a little bit about the example and how their informatics people were a central part so that you can understand my mental model on the roles and opportunities. But first, before we could design something, back in March, we went back to Deming. Deming, the father of all manufacturing quality, argues a system of profound knowledge. And at the heart of that, of course, is good informatics, is 4 principles. Number 1, appreciating the system. And just because I thought I'd bring his book so you can see what it looks like as well. Number 1, in appreciating the system. Number 2 is understanding and measuring variation, the heart of all quality. Number 3 is the understanding of knowledge and how to change behavior. And finally is the issue of trust. If people don't trust you, they're not going to change their behavior. So we designed a pandemic informatics dashboard based on Deming's model. I'm going to show you that. The second book we used was this book over here, Donald Norman's book. This is the new cover of it. So Donald Norman, who is an information scientist and a human factors engineer at UCSD and Northwestern, argued that all systems, all outcomes are always at the fingers of those who design the system. So if you have clunky EMRs or clunky COVID dashboards, it's because the informatics people who designed it fell short. What Norman argues is that the designers are responsible for the product. And so if we want to have better improved products, we have to teach the designers, the students of informatics and linguistics and learning technologies, how to better understand what Norman talks through. So here's some examples of systems that have failed. This is the science of human factors. Can anybody point out the problem here? Or this one? Or this one for all the men in the room? Or this one? This was a handicap ramp at a hospital? Or perhaps this one? Can anybody see what's wrong with this CAT scan? This is not a design problem, but this was an exercise to try to understand, would the clinicians see that there was a huge gorilla in the middle of the CT? Can you see the gorilla? Can you see the gorilla in the black on the right side there? So yeah, can you see that? Let me see if I can annotate it here. So here's the gorilla. Can you see the gorilla? So it turns out that 50% of radiologists missed the gorilla when they read these CTs looking for pneumonia. And the point of this study was, if your eyes are looking for pneumonia, you're not going to see the gorilla. And so we, as system designers, as information designers, can help people see things. We call that learning to see, or we can help them not see things because they're distracted by all the bells and whistles that we've designed into the system. I'm having a hard time releasing my slide here. There are a few hands up. So let's take the first one, please. Are you seeing the questions, Mike?
I don't see it in the chat box. Did somebody raise a hand? Speak up, unmute.
I only see Mike's hand.
Okay.
Oh, it's
perfect.
me? Oh, I'm sorry.
I think so.
Yeah, I was just trying to encourage other people. I was responding to Paul's comment that we ought to have ethics. It's embedded a little bit, change management and ethics in some of the courses, but it's not a separate course.
No, so
but I hope people will unmute themselves and ask questions because, yeah, I know there are a lot of thoughtful people here in listening in.
So the next thing that I hope is part of the curriculum is process management. You know, we like to think that this is what the work looks like, but in reality, this is what when I look at patients, and I think you have to touch these again, otherwise I can't move. So what am I doing wrong, Michael? Why won't the screen move forward?
I don't know. Can you right click or?
Can't do anything. It's almost
I don't see what you see. Yeah, so I can't do that.
So let me, as I'm fooling around, any questions about, so what I wanted to share with you was the science of process management. Lean, Six Sigma, and Agile is all about understanding not just the work as we imagine it, but the work, the real work. So for informatics people to understand what it's like to design a better information system, that would mean they have to go what the Japanese call to the Gemba. So going to the field where nurses and doctors work, and I'm constantly surprised when I meet informaticists in hospitals or clinics, how many of them stay in their offices but don't actually go to the workspace. And when I ask them, they go, I don't want to get in the way and I don't feel comfortable there. So I'd rather they tell me what the problems are and I will design solutions for them. And I would argue that you have to actually go to the workspace if you're going to understand the context of where the problem resides. And I'm having a hard time for some reason moving my slides forward, and I'm not sure why that is.
Adam, if you're still there, is there, should he exit and try to restart again, or?
Yeah, that's what I was going to recommend. Paul, can you try maybe stop sharing your screen and maybe you could play it again?
It looks like it's locked into this. Okay.
Yeah, the share stopped. I think there. Yeah. I think so now, Adam's going to recommend resharing, and then maybe it'll work correctly.
Yeah, I hope so. So the science of process management, which is an incredibly important science, is something that is regularly not taught in informatics programs. And so this is a plug to in fact, introduce those elements. Where are we? Right here. Okay, can you see my slides now?
Yeah, they're back.
Okay, so and so I the reason I brought that up is because so much of what we've learned is about understanding the process. So for informatics people to design optimal solutions, telehealth, telemedicine, or any of those tools, they have to be in the front line of work. And what that means is to prevent those problems is this is what the ED looks like. This is real patient flow. This is what the graphic looked like. Can you see the difference?
Yeah.
It's this is a spaghetti diagram. And so, in reality, this is what workflow looks like. This is from Joanne Westbrook's group in Australia. Does a lot of work on informatics. And you can see here using a time motion study, looking at who talks to who when, the work as done is very different than the work as imagined. And that means teaching people the science of process management. So this is Pascal Carrion's work from Wisconsin, looking at outcomes process work systems and the science of human factors. I would suggest that this is an essential part for information scientists to understand how the work gets done, how we look at it together, and how best to measure it. These, of course, is the forefathers of human factors, Jens Rasmussen, and all the ideas to think about the science and constraints of adaptive system science. I don't have more time to go into it, but I would argue this is another essential part for the science of informatics and the nexus between linguistics, information science, and learning technologies. Now, briefly moving to high reliability technologies. So we've talked before about cultures, and I showed you Ed Schoen's work. And so this is another important theoretician, Carl Weick from the University of Michigan, who argues that if you want to produce great outcomes with great information systems, you have to think about these principles of mindfulness. How do we design information platforms that help clinicians and executives be mindful about failure, being sensitive to the frontline work, what the Japanese call gemba, reluctance to simplify, even if you can do it every day. Just because Boeing jets take off every day never makes it simple. Every day they can crash. And in fact, sometimes they do crash. This commitment to resilience and agility and understanding that the people that need to make the decisions are the people on the front line of work, not the people who design the systems, the people who do the work where value is created on the shop floor. So when we think about organizational culture and cultural scientists, and we think about what is it that gets people to change their behavior, here's another important book that I like to use a lot. This is Diffusion of Innovation. This is sort of the science of how do you get ideas to change organizations. And as part of that work in this model is that the culture is how you get information technology to change people. And that's about trust, transparency of data, and truthfulness in reporting. Very important elements around the social sciences. Here's an example from a study we just did in Norway. Half of the country, about 2 million patient cases. And we surveyed 9,000 physicians. And what we found, and nurses, that there was a direct correlation between nurses' empowerment and patient mortality. If nurses felt disempowered, disrespected, more patients died. And it was independent of the work of physicians. Again, a very important informatics piece of work, looking at how the engagement of clinicians through information tool sets could help engage and empower nurses versus disempower and disengage them. A second project I want to share with you, this is a high reliability model. Again, if we're looking at an organization and I need good data around quality, safety, throughput, cost, and culture satisfaction. So in this project, we mapped out the surgical process. So this is what we would do. So I work with the people in charge of enterprise information in the system. We map out each person's job in each of these phases. Then we do what's called a swim lane map. So you can see on the left, the surgeon, the nurse, the scheduling, the administrators, and then on the horizontal, all the actions that are taking part by these teams. These tools allow the data information people to understand how data flows across the task of the different clinical members. Then what we do is that we take a time motion milestone, and each of these T's is going to be marked by an annotation in the EMR. This will allow us to better understand how long it takes for the patient to move from the pre-hospital to the hospital, in the hospital, from the operating room to the intensive care to home. The system, Epic, for example, only captures about half of these data points, which means there's a lot of what we call black spots here, and where there's waste of time, waste of energy, and harm caused to the patient. This is a way of using process mapping in order to better understand the data sets that you need to design better metrics, and ultimately, in this case, to design Power BI tools to have push and pull systems that would allow the clinicians to get information in real time. This is another tool we use called a SIPOC diagram. So we go what goes in and what goes out. So in this case, it's about scheduling and the pre-operating room. But imagine you did this for every service in the hospital, for pediatrics, for nursing, for surgery. Each of the steps is mapped out. And once they're mapped out, we can then do a Pareto chart looking at the waste. Then we can do a waste analysis. Where is waste happening? And how is the data helping the executives and clinicians understand the defects, the waiting, the transitioning. And finally, we can then ask clinicians, what do you think are the most important things that would help your system improve? In this case, surgery, but you can imagine applying this. These are tool sets I think that the informaticians of the world need to learn so they can be more effective in helping the clinicians understand their needs in language that's common. This is finally, I want to share with you a failure mode and effects analysis. This is a tool we borrow from engineering, and in which we actually quantify what is the risk and what is the frequency and what is the severity of something that's missing. In this case, it could be a case that's not scheduled, it could be a piece of equipment, or it could be an infection that was caused to the patient. So here's where the data informatics come in. So we work with them. These are the metrics that we designed for this hospital before surgery. So each of these metrics would have to be defined. Then it would have to be code written for it, so it could be put into the Data Electronic Medical Board, EMR. And then you can see here how each of the indicators on the left, where the data source comes from and when it will happen. In this case, green is stuff that we've developed, yellow is stuff that's going to take 2 to 4 weeks, and red is going to take a month and a half. So this is how using the map, the data, the cultural aspects, the engagement of the clinicians, then the mapping of the clinical workflow, then the metrics work with the clinicians, and then finally bringing in the informatics people to design better metrics. Before I move on to safety management systems, are there any questions or comments thus far?
Yeah, I don't see any in the chat box, but hopefully somebody will speak up and ask.
Can I just make a comment? I think you're talking there. You're making very interesting points, and you're basically putting together, like, the quality management and the, to the system. And because the systems do not necessarily make quality management issues, I think this is something, very important. But the major gap is, there is from the clinical side, they have this clinical information, and then they don't know much about quality management. And then you have quality management people out there, they don't understand the clinical side. So we have this gap over there, and then when they come together, they don't speak the same language. And
no, absolutely. And then it gets worse because then they hire consultants like me, and then they don't listen to them. So then it doesn't really help. The truth is that, you know what they say about consultants, my job is to take your watch and tell you what time it is, and tongue in cheek. But the reality is that unless you build this into the DNA of the executives, unless they understand this is a model for a safety management system, imagine designing the information back with the backroom, the backflow for this that would allow the system to be a learning system. At the end of the day, informatics is useless. Data is meaningless unless it allows the system to learn, to harvest the lessons and to apply it from room 1 to 2, from patient 1 to 2, from cohort 1 to 2, from hospital 1 to 2, right? So unless it's an iterative system that's learning, it's very difficult for it to follow and grow. And if you use David Kolb's model, one of my favorite pedagogical models on experiential learning, in clinical informatics is all about observations and reflections. How are the dashboards used? How are the databases being applied? Are these scorecards helping to make better decisions? Because if you give me data that's not actionable, don't give me the data. It doesn't help me. Executives are drowning in healthcare data in the US. That's not their problem. Their problem is that the data is not actionable. It's not helping them to make effective decisions. And so even though there's lots of data, it falls short in helping to make better decisions, allowing the system to be more profitable, more safe, better service provided, and better supporting of the clinicians. This is the safety management system we built. And again, a very, very strong bioinformatics background, about 25 people. And you can see on the left, incident reporting systems, huddles, culture, harm, and you can see how it's being planned over the next several years. A very complex system with a budget of maybe $100 to $100 million or so, given all these things. But a lot of it is the social engineering, the change management to get the clinicians to agree. One of the biggest problems in the US, as you may know, is that less than 5% of adverse drug events in hospitals are reported by doctors, and about 20% by nurses. That means that at least 80% of harm that's caused to patients by drugs doesn't get reported. Think about that for a moment. All that learning is lost. Aside from the fact that we're harming patients, aside from the fact that we're losing money, and aside from the fact that people feel embarrassed and ashamed, the system has no mechanism to learn more effectively. So the same typology of events happens again and again and again. Back
Paul,
to Jefferson.
I wonder if I could, because I know you've worked in other countries quite extensively, and if you could compare your experience with U.S. medical care systems with some of the ones you've seen elsewhere.
Yeah, and absolutely. I mean, and I want to be very careful here. I mean, there are thousands of systems in the U.S., and so I'm taking an average. But there's some very good systems in the U.S., like Cincinnati Children's, like Mount Sinai, like Stanford Health. So there are many systems that use what you're going to see right now: a good safety taxonomy, a smart use of mobile platforms, constant documentation that's thoughtful, relational databases that use AI and machine learning and deep learning, but in close context with clinical needs, constantly talking with the clinicians and caring for the providers as they deal with this. So I saw much more of this, Michael, in Norway and the Netherlands, because the national platforms were much more rigorous. And even though there's a lot more private healthcare in Australia, the national platforms are much more aligned around financial incentives and around professional incentives.
Yeah, I expected that would be what you found. Yeah, thanks.
So for example, here, this is again, we put all of our guidelines, all 150 of them in this case at Jefferson, so people could access them wherever they were. These are other tools that we did there. And so I'm summarizing it very quickly. Each of these boxes is almost a curriculum in itself. It's a mini course that you'd have in your college. Very, very challenging literatures and building blocks. This is the enterprise command. So we took a command and control structure. And this was designed just for the information people. So this is about 45 people. This is how it was reorganized around COVID. This is something that we planned 2 years ago to make sure that the demands put on the information people were reasonable and manageable given the tremendous COVID surges, in this case in the East Coast in March and April, now of course happening in the Midwest, etc. Then we built a service data dashboard. This is what it looks like. And so you can see this was built within 2 months to allow the executives to have almost near real time how many beds, when are they being sick, from what floor, at what time. And so this was a targeted just-in-time development designed for COVID in order to give better actionable data for the executives who would have daily huddles 3 times a day to make sure that they weren't being overwhelmed by COVID cases, by staff infections, by other types of concerns. Here's the real database. I'm going to show you this. So this is what it looks like. You can see here April 8th, different services. Here's another snapshot, how many masks we had, where were the masks being used, how much were being utilized, who was quarantined. So regularly, and here you can see how many this is how many staff were infected in the system. Of 8,000 employees, we can measure day to day by using a bot and by using self-assessment and stuff like that. Yes. Here's our mortality. This is a data dashboard. This is from March to July, and you can see how many patients died, where they died, et cetera. This data was being fed every day to all the clinicians. So we call this radical data transparency, not secrecy, which is very common in healthcare. Here you can see every day we'd send this out. This would be an intelligence report that every clinician executive would get every day. What's happening around the world on the bottom, how many cases we have in the middle, and up on top, how many cases around the world. The top thing came from Worldometers or Johns Hopkins. The middle came from our data management, and the bottom came from our PR media office. Every day, this is what every clinician and manager would get. So now I want to wrap up my final section around trust, and this is from Patrick Lencioni's work. You know, if we're going to get to diffusion of innovation, we have to make sure the staff trust us. And if they're going to trust us, we have to create a culture that's a just culture. And that means that we treat people with integrity, that we focus on trust, and we hold them to account around their engagement. And that's not always easy. This is Amy Edmondson's work, who argues that the best organizations, healthcare and not, are those that have psychological safety, where clinicians and executives feel safe to say, I disagree. So do we have a fearless organization? And are we teaching organizational culture change in Texas? And if we're not doing that, why aren't we doing that? Because unless we get there, unless we teach them what humble leadership looks like, in the executive training, they're not going to understand, and then we're going to get another challenger. And you could argue that the number of people that have died from COVID is an indictment for our healthcare system and decision making, and very similarly to the Challenger disaster, although that was 7 or 8 astronauts. This, in fact, in many ways is bigger numbers, but the pathophysiology looks very, very similar. Now, how do we evaluate all these things? And so a few words about evaluation. I do a lot of work on methodologies and what are the proper trials. You know, we like to say RCTs, but very difficult to do randomized controlled trials. So we really need to have a deep dive for informaticists about how to measure things, if it's adaptive trials or Bayesian trials or other types of wedge-based trials. The whole science of methodologies has dramatically changed in the last 10 years. And I think that needs to have a much stronger presence within the curriculum in College of Information Science, so they can demonstrate that their innovations and changes are actually making a difference at the outcome, or upstream at the process, or upstream at the structure or policy levels. Finally, this idea of quantitative, I'm sure you must have seen this special issue, Michael, in the Sunday Review 2 years ago, arguing that universities have completely lost the plot because they keep on using quantitative tools to assess impact and joy of students. And as they've done that, the faculty are annoyed, the students are annoyed, and the outcomes are very middling. And so sure, quantitative outcomes are important, but not by themselves, and not when they're not connected to key qualitative aspects around joy, engagement, satisfaction, friendship, empathy. How do we make sure that our universities and hospitals and medical schools don't put out people who have very little empathy, very little joy, very little support systems? They might be very good technically, but non-technically and socially, they are misfits, and all of us will suffer accordingly. So finally, what happened to our safety management system after COVID? Here's what we learned after 6 months. Number one, we have to tell the truth to our patients, to our staff, and to our executives. That means that they must feel psychological safety and not fear. Number two, this isn't a corporate exercise. We mean this. If we are truly aligned, we have to align our financial metrics and our promotional metrics. If we continue to promote people who misbehave, if we promote people that publish lots of papers but aren't particularly influencing change, if we promote bullies and tyrants and disruptive people, that sends a much, much more powerful message than nice memos and manifest and other types of exercises. We need to measure better. So in the information space, we need to get better ways to demonstrate that data tools, and I shared with you a paper that we just published, one of the first papers in the US using patient-facing technologies, in which we show that bi-directional text-based tools can help reduce the workload on clinicians after surgery when the patient goes home, increase the satisfaction of patients, and reduces their pain scores. This was done on 3,000 patients at Methodist Hospital in Houston. And if you've not seen the papers, I'll send them again afterwards. Finally, this whole issue of high reliability and how to make sure that we focus on the frontline people. We talk about trust and truth-telling that helps to build transparency of the data systems, and that builds engagement, which we know is the most important thing in keeping our employees and staff satisfied, that keeps our patients becoming our best marketing people. See Mayo. Mayo, their most powerful marketing tool is their patients, not their PR arm. And that is all about high reliability. So from COVID, we learned that designing solutions is about empathy and compassion. That means teaching people, that means teaching students in faculties of science and information. How do you become more empathetic in your work? That means safeguarding the wellness of the teams. That means learning how to message more effectively, understanding the narrative, using transparency and truthfulness, and having a regular cadence that we can get through this in a calm, clear voice versus some of the macro political voices that we all know about has been part of the COVID disaster in the US. So my final slide is one of my favorite scientists, Avidis Donabedian, who was an information scientist out of Michigan, died several years ago, who wrote about the secret of quality is love. And what he argued was that systems awareness and system design are important, but they're not enough. They're just enabling mechanisms. It's the ethical dimension of individuals that's essential to a system's success. Ultimately, the secret of quality, and you could argue of information science, is love. That means you love your work, you love to improve it, and you're totally engaged to the process and what goes around it. So I think this is it. So again, process design, culture design, and human factors need to be a central part of all curricula for information scientists. I think that's a good nexus between your three schools. And then I'll just end with this quote: no matter how well your equipment or bioinformation tools are designed, no matter how sensible your regulations are, no matter how good your people are, they can never be better than the system that they're designed around. And this is from the captain of the aviation safety model, arguing that we need to design better systems if we want our users to be more effective in their workload. These are some of the books that we've published on this, my email and telephone. Thank you so much for your attention. I'd be delighted to answer any questions and of course, share with you all these slides and the reference materials. Thank you.
Well, thanks. Yeah, first of all, yeah, that was outstanding, Paul. We really appreciate it. So, but I'm sure that hopefully the people will have some questions for you. Yeah, just unmute yourself and ask away. So one of the comments I made in the chat session was a lot of the principles you talked about seem applicable well beyond the medical domain.
100%. You know, I've been working with an organization, and they're trying to train their next generation of informaticians, and it's not about healthcare. These principles are good practice. You know, using Lean Six Sigma and process mapping is not about healthcare. Every industry does it: aviation, nuclear power, manufacturing. We in healthcare have to reinvent so many of these fundamentals, and which is bizarre at times, but it's unfortunate that the healthcare executives, many of them aren't always attuned to these principles, or they think it's like, I want you to help me for 4 months. Thank you. I don't need you anymore. These things are not band-aids. They're genetic code issues. They're essential for the survival of the organization. When you have so much turnover of nurses, when you have so much burnout of physicians, when you have executives that turn over every 2 years in healthcare systems, these are fundamental principles that are not unique to healthcare. But of course, healthcare are some of the worst applied models in which we see that when you fail to design systems these way, you have more burnout, more harm, poor service, and more unhappiness while unsupporting of the community needs.
Yeah, right. Other comments or questions? So it seems like one of the messages that I'm getting from this is this the sort of the value proposition here is that in the medical setting, you expect people to care about their work because they want to help patients recover and do better. And in the educational domain, you would expect that we care about our work. We want our students to progress, to grow, to increase understanding. And so, but in the decision making within a system, that care and what you called love in that last slide can easily be overlooked, and then everything gets monetized. So it's just, oh, we're going to reward the professor who publishes the most, and not necessarily who cares about the most learning for the student. Or and I don't know if you want to react to that or not.
I think so. I mean, I think we have to realign our value system here around what actually adds impact. I think fundamentally we have to ask the question, how do we actually know that our present model is delivering better value? And when I say value, I mean not just more publications or more grants. That's very important. I love to do that. But is it actually bringing joy to the faculty? Are the students coming out enthusiastic and supportive? Is the community engaged with what the university or colleges are doing? Are we actually having impact on social issues, on cultural issues, on phenomenological issues? I think we have to dig in deeper as academics and scientists to ask more deeply from a lens of implementation science, how much of what we're doing is actually having an impact. Because it's like when you look at Google Scholar and you see some papers you worked on for 3 years and 5 years later, nobody's even cited it, and other things you threw together and there's like 200 citations. You're like, wow, it's very interesting how the marketplace influences how you look at your own work. So I think we have to get more rigorous and more self-reflective, Mike, in looking at what do we know is working well and how can we improve it?
Yeah,
I had a question for you about COVID. I'm sorry, Mike, I didn't mean to interrupt.
No, go ahead. Yeah.
Just in, say, relation to how long is this going to be sustainable in terms of people getting information by the time they actually reach, like, say, the hospital system? When we're talking about the frontline workers who are being transparent, I think sometimes that might be the first people they've heard telling them the truth or telling them or being transparent about COVID. I mean, we get numbers every day, and I looked up the numbers for Michigan today, and it said 5,710 new cases just for today in Michigan.
Yes.
And so I just don't, how is that going to continue to be sustainable, or is it?
That's a really, really hard question. I think we're in for a seriously extraordinary, difficult winter. And I think it's going to be really bad. I think that this will be on par with the Spanish epidemic in the US. It's going to be really bad. And it's going to be bad because we've ignored it. That's why. And that's tragic. There's no other way to say it. And there are models around the world, small and big countries like New Zealand and Norway that have done really well. Taiwan at 28 million people. Germany was doing really well until the last 5 weeks, albeit problems now, but a country of 80 million people. We could do so much better, and we have failed on multiple yardsticks. So I'm glad to talk about that offline. That's a big, complicated issue, and I've given multiple webinars on that. It's hard. There are many ways we could do better, and we need to do better. But all this disinformation, false targets is killing the spirit. It's killing the vibe, and it's killing the trust. And that, in so many ways, is at the heart of fighting all pandemics.
Right. Yeah. I have a son that lives in New Zealand, and I'd like to go there, but of course we're not allowed to enter the country.
No. So I mean, we're heading into a very difficult window, Eva, and right now it's 100,000 people a day. I wouldn't be surprised if we continue this course that by the end of the year it'll be about 250,000 a day. Exponentially, it'll continue to grow. So, and that's hard.
Yeah, I think I saw in the news today was the highest number of cases yet. Yeah, in the U.S. Yeah, and the Spanish flu thing, it's a 2-year run. So, you know.
Yep, and it was a lot worse. The second, third, and fourth waves were much worse than the first wave.
Yeah.
Can I just make a comment for you? There was a discussion saying that, you know, there needs to be a new system in place, like integrating, you know, the health, public health, and the medical system all together in order to fight these, you know, pandemics. And you have mentioned that public health, you know, lost its trust. I'm not sure if it lost its trust because it was not even able to function, you know, properly because the system itself is not, you know, that well. So what are your thoughts on that?
I mean, in the US, public health has been terribly damaged. In many countries, public health has been under attack. The tools of public health are actually pretty good. And although some public health leaders were overzealous, agreed, but it's fair to say that in countries where there's respect for science and public health, they're coming out of this pandemic much, much better. To be clear, I'm worried much more, not just about the pandemic, I'm worried about vaccinations for the measles. I'm worried about heart disease prevention. I'm worried about cervical cancer. I'm worried about all the other non-COVID issues, which are so much worse because people are saying, well, if they were wrong on COVID, those public health leaders, maybe they're wrong on everything else. So the worst case scenario is that our overall population health gets much, much worse directly because of COVID, that's clear, but more importantly, by sheer numbers for all the other lack of follow-up, lack of compliance, lack of understanding. That's an extraordinary challenge that might take us back to 10 or 20 years in our overall population health approach.
Yeah, and earlier today I was in a meeting where a senior retired professor emeritus, his wife is due to have hip surgery, but she can't do it because she's in a place where the hospitals are not taking what they consider non-critical care. So, and as she gets older and her hip gets worse, I mean, you know, who knows when she'll have the surgery she really needs. So it's like this crisis leads to more crisis.
Many, many more. And that's where, you know, the political science and change management, I think, is critical for information scientists to be taught and to be part of. It improves their research. It improves their understanding of the runway they can work on. And most importantly, it allows them to be more effective in their job. Mike, I'm supposed to get on another teaching session in about a few minutes.
But, we appreciate your time. Thanks so much, Paul. This has been great. And I'm so glad you're willing to share this. So we will share it widely here. So I think it's been outstanding. So
it's a pleasure to see you again. Pleasure to meet you, Eva, and everybody. And I'm delighted to follow up individually and otherwise on different projects. I didn't talk enough about some of my own research around these things, but there's a lot around that. I'd love to talk about collaborative work at the master's level or PhD level or otherwise.
Absolutely.
As we think about
once COVID passes, we'll get you here in person.